Okay, so in this podcast, we'll be talking about atrial fibrillation. Let's talk about the epidemiology, some risk factors, age, obesity, hypertension, smoking, history of alcohol use, and diabetes. Also, a history of previous MI, heart failure, or very important and prevalent one, obstructive sleep apnea. It usually recurs in majority of cases due to secondary precipitants, stressful events like surgery, infection, MI, and PE. So always think about secondary causes as well, especially new onset A-Fib. So clinical evaluation, you start with history, presence and timing of onset. You look for the factors like hypertension, diabetes, previous angina, congenital heart disease, um, and medications as well as thyrotoxicosis, get TSH, and presence of underlying infection as well. So ECG is the first test to be done, and you see absence of discernible P waves, usually in lead 2 and V1, and also irregular RR intervals. Um, you can also get a TTE, and a lot of the times you know look out for LV dysfunction and left atrial dilation, as well as possible concomitant valve dysfunction, pulmonary hypertension, and looking for left atrial thrombus, especially if the patient hasn't been on anticoagulation. Labs, thyroid function tests, always important to get on newly diagnosed A-Fib, liver function tests, BUN creatinine, CBC, and a BNP as well. And in the outpatient setting, always important to get a long-term rhythm monitor to evaluate for whether it's paroxysmal, permanent, and also consider a stress test, especially if there is signs of ischemic heart disease. And there's also new smartwatch notification. New England Journal of Medicine in 2019 showed a positive predictive value of 0.84 for A-Fib on subsequent simultaneous EKG in patients, and these are patients greater than 65 years of age. So in the next podcast, we'll be talking about addressing atrial fibrillation, whether hemodynamically stable or not.